just gonna give people a minute. I think it's 8:30 in the UK now. Nearly time to start. Okay, so we're on YouTube now. That's good. Got it. And and I'll start with my usual stuff here. Well, evening everybody. Welcome. We're very lucky today to have Christian Dumontier, and I was saying to the fellows today that the name is familiar to us. Is mostly for the paper on the classification of radiocarpal dislocations, which is a paper that we quote quite often. You know, although Christian has written on a vast variety of topics. You know, and I feel very honored and very grateful for him to be here with us today. Thanks to all the people who endorse us, plus the UK and Bota from the UK. Segma, gracias Eduardo, como cada semana. BAPRAS and BFIRST and the BSSH. Excuse me, there is still war in Ukraine. Our fellow doctors there are struggling, particularly trauma guys, plastic surgeons and orthopedic surgeons working very hard. If you can do anything to help them, please do. Have a think. There are lots of initiatives you can collaborate. And many people are helping. I will not say what they're doing for obvious reasons, but it is very encouraging, the solidarity that the community has. Previous webinars can be found freely on YouTube. So if you go to YouTube, put Pulvertap videos and you'll get them there. Just another reminder that FESH is going to be in Rimini a bit earlier than usual. Usually FESH is the first week in June, but this year is like the second week in May. So time to get things ready. Book your trip, book your accommodation. So it's going to get busy. Next week is the instructional course of the BSSH. That's in Manchester. And it's 2 days, Friday and Saturday. Friday is lectures. If you cannot go, but you're interested, you can just register to have the lectures available or even available online. And that's quite cheap. So I'll put the links and have a look at the website and see the different options. So you can go for 2 days, you can go for 1 day, you cannot go, but follow them live, or you can just want access to the talks afterwards. Is all there. And the topic this time is hand fractures and joint injuries. Important topics. My only request, as always, fill in the questionnaire, the feedback questionnaire at the end. That helps us a lot. And I'll put you this quick quote at the end. So if you want to aim your phone at that, it will open the questionnaire for you. And we're going to have a little break on the webinars for 2 weeks, just because I'm doing other things. And the next webinar is Jeff Greenberg, who's just been president of the American Society for Surgery of the Hand. And I've known Jeff for over 20 years. He's done a phenomenal amount of work in Indianapolis. The Indiana Hand Center is one of the big and historical centers in the US, where Jim Strickland was one of the people who started it. And they have a vast experience in the IUJ instability and managing the TFCC and understanding the biomechanics. So I'll leave it at that from my point of view. Stop share. And evening, everybody. You're just joining us. I'll put you the links on the chat in a minute. And Jill, the floor is yours.
Thank you very much. So before I introduce tonight's speaker, please can I ask you to remember, if you'd like to ask Professor Dumontier questions, please use the Q&A link at the bottom of the screen. That's what I'll be monitoring at the end of the talk. So I'm delighted to welcome Professor Christian Dumontier to give this evening's webinar. He's got a wide training both in microsurgery, hand surgery, general surgery and ethics. He has a PhD and was a professor in Paris. Then he moved at the Centre de la Man. Then he moved to Nice, and now he's in Guadeloupe, which is where Death in Paradise was filmed. Although looking at the background at the moment, they're having a freak weather event. He's a teacher of international and national repute and is responsible for the Hand and Upper Limb Diploma. He gives presentations around the world and has continued his interest in research with over 100 publications on a huge range of topics. I'm delighted to welcome him to talk about traumatic nail injuries. Thank you very much.
Thank you very much, Sheila and Carlos, for inviting me. I'm going to share the screen and go immediately to the topic. And my talk today is about the nail, the anatomy, the physiology, and the management of traumatic injuries. I understand that nails may look a little bit tricky or small to most of you, but it's a very frequent injury, and knowledge of the basis, which is basically the anatomy, is what we need to take care of this patient. I can already tell you my conclusion. You do not need to be a very skillful surgeon to do nail surgery, but you need to know the anatomy. That's a major issue. Well, Guadeloupe is a small island in the Caribbean Islands. It's an archipelago of 5 islands, and I'm working here, basically in the middle between the 2 islands. In fact, it's not a single island, but it's a small river. This is what I can see from a house. It's what from my friend's house. Well, what do we have nails? Well, only primates have nails. And the nail unit, what we call nail, is a nail plate, and it's produced by the nail unit, is part of the fingertip. So nail injuries will not be different or separate from fingertip injury. Usually they're very associated, we'll see that later. And it's a part of the trauma of the distal finger. The first thing we had at the beginning were claws. So what do we have nails? Basically, during evolution, claws were very useful, especially like from the squirrel to get up and down. But as our size increases, we need to go to the top of the tree to get some food. And if you weigh more than, let's say, 1 kilo, then claws are not anymore sufficient. You need to embrace the tree and get some friction to reach the top. And then you do not need claws anymore. And nails, even if they have a little advantage, it may help. And that's why we'll keep claws, went to nails, and would still have nails. It has changed. If you look to the down of the page, you see the old phalanx of the Olduvai, which is basically 3 million years before Christ. And the phalanx we do have right now, you see, it's very different because more and more we are using our fingertip, and the nail is part of the fingertip, remember? And we need to accommodate with a very sensible pad. The fingertip is very sensible, and nails are useful with that. So the nail unit is a distinct organ. It is on the top of the fingertip. It represents roughly 25% of the fingertip, but it is a distinct organ with a distinct anatomy, with a distinct physiology. And that's very important. So you probably all know the physiology and the anatomy of the pulp, but the anatomy of the nail is to be learned also because it participates with the fingertip. That's very important. So what is the anatomy of the nail? I will go, I will say slowly because we need time. First of all, even if it's not nail, you need a bony support. As you can see on that picture, unfortunately, I cannot see the slide, the arrow. You see the nail plate, you see the endostructure, we'll see that later. You see the phalanx, the DIP joint, the flexor tendon that appears, and all the nail is on the bony support. That's very important. Not only bones, but there are some ligaments all around. As you can see from the left-hand side, bottom side figure, you have the extensor tendon, it's number 2. The collateral ligament is number 3. You understand that volally you will have the flexor tendon. So every structure goes to the base of the distal phalanx. From that base, you have ligaments are not represented here, but you have also number 1, which is an interosseous ligament, which was described by Flint in 1955. And it's basically where the nail unit is fixed laterally. And you see on the right bottom side that this ligament is very clearly visible in that case. And it's both an anchorage for the nail unit and also protection for the vessels that are coming from the volar side of the fingertip and pass protected by that ligament to reach the nail apparatus. As a consequence, you cannot have a normal nail if you don't have a normal bone. For example, if you have bone loss, like 2 upper pitches, you can have a hook nail deformity because you miss the support. You see the nail matrix and the nail bed with the nail plate, which is a little bit black, and you see there's no more bone, so all the nail unit is bending up. Everything is intact in the nail, but you cannot have a normal nail if you don't have a normal support. And the same if you have a ridge, like in the middle of the picture, you will have some dystrophy. If you have a large phalanx, you will have racket nails, and so on, and so on, and so on. So if you are going to reconstruct a nail injury, you need to reconstruct the bony support and the pump at the same time. Well, the nail apparatus can be divided by the nail plate in 2 structures. Above the nail plate are what we call the paronychium. Basically, there are the lateral fold, proximal fold, lateral fold. So the soft tissue around the nail plate. Under the nail plate is the perionychium, which are divided in nail matrix, nail bed, and hyponychium. We'll go with that. Let's start with the perionychium, which is a major issue. From proximal to distal, you will have the nail matrix, which is also called the germinal matrix, which means that it is where the nail plate is made. So the nail matrix is mostly hidden by the proximal fold. You cannot see the nail matrix in most patients. Then you have another structures, which is called the nail bed. I prefer nail bed than sterile matrix because a matrix which is sterile, it's no more useful. So it's not a matrix, it is a nail bed, a structures that will hold the nail plate in place. And distally, you have the end of the nail apparatus, which is called the hyponychium. Regarding the nail matrix, it starts very proximal. Remember the DIP joint. The extensor tendon insert on the distal phalanx about 1.2 millimeter. Then you have 1.4 millimeter with a soft tissue, and then the beginning of the matrix. That means the nail matrix starts, let's say, 2.63 millimeters from the DIP joint. So it's very, very, very proximal. And it's end up distally at the level of the lunula. You do have lunula on the thumb. It is a white convex area. It's always visible in every patient on the thumb. In some patients, like in this one on the slide, he had lunula on every finger, which is quite unusual. That's why I took the picture. So basically, the nail matrix is protected by soft tissue. So that's very important. I'm very unhappy with this arrow. On the left bottom side, you'll see a pathologic specimen, and you see the nail plate, which is the white structures. The nail matrix is the purple one, and it goes under the nail plate, but it goes also over a little bit. So the nail matrix encircles the nail plate at its beginning. More distally, it's no more nail matrix, it's skin tissues. I mean the word, I'm sorry, in English. First and foremost, very important, the nail matrix is the only structure that is able to produce nail plate. No nail matrix, no nail plate. And it cannot be replaced by another tissue. If you have lost your nail matrix, only a new nail matrix, basically nail matrix grafts, can give you some nail regrowth. No matrix, no nail. That's very, 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 very important. The second, a little bit more destructured, starting from the lunula, is the nail bed. It's also a very specialized structure, and it is responsible for the adhesion of the nail plate. If you go with a microscope, you will see ridges in the nail bed, and those ridges interfere with the ridges under the nail plate, like the escalator in the supermarket, that hold your caddies and you go with that. So those two structures interfere, and they are very, very, very much adherent. When you pull out a nail plate, you always take parts of the epithelium of the nail bed because they are so much linked together. It is also responsible of the shape of the nail plate. We'll see that a little bit later. What is important, in acute cases, in emergency, it can be replaced by dermis graft, skin graft, and so on. So you can sometimes replace the nail bed by non-nail structures, which is not true for nail matrix. But only in emergency, there's some tolerance. If you do reconstruction with not a nail bed graft for dystrophies or chronic diseases, it will fail. And the clinical consequence, if you don't have a normal nail bed, then you cannot have a good adhesion of the nail plate, like in these two cases, where the matrix is okay, produces nail, but the nail bed is destroyed, and then you have dystrophy. The hyponychium is a very thin, very small structure. It is where your nail plate lost its adherence. Okay, so what? Well, now for those who didn't know that, look to your patient. When you do a flap, let's say just an nasal flap, most patients will complain of abnormal adherence of the nail plate to the scarring tissue. And it can be very, very painful. Your flap is okay, it's perfect, your nail is perfect, but the hyponychium might be replaced by scarring tissues, and it's then a problem. So that's a major issue for dressing or flaps, is the non-reconstruction of the hyponychium. So it's not the topic, but it's very easy to replace it. You just put a small skin graft, and the nail plate will not adhere to the scarring tissue anymore. The second function of the hyponychium is immunologic. You are grasping a lot of things. You are always having your fingers in the mud or whatever it is, and you don't have infection under the nail bed. It's obviously because they have big adhesion of the nail plate to the nail bed, but also because the hyponychium contains a lot of polynuclears that avoid abnormal infection. Above the nail plate, the paronychium, the two-fold, the proximal one and the lateral one. The proximal nail fold is the structures that encircle the nail plate. And what is important is at that level, you have a small seal, which is called the cuticle. It's visible on the left bottom side. You see the skin. This is a big view. And you see the small piece that advances like a beak. This is a cuticle that sealed the nail plate with a proximal fold. This is the cuticle that the manicure are trying to push back, and then you will have onychomycosis. This is a major issue. If you lose your cuticle, then bacteria, fungi, and so on can go under the nail fold, stay there, and then you will get an infection very frequently. This proximal fold is also responsible for the shape of the nail. We'll see that. On both sides, the lateral fold that encircle the nail plate, and they are also responsible for the shape and the orientation of the nail during growth. You can see that, for example, for those patients with syndactyly. And finally, between the perionychium under, paronychium over, you have the nail plate, which is the production of the nail apparatus. It's, as you can see, supple structures that has a double convexity, which is very beautiful. And it's this separation. So the shape and the quality of the nail plate will depend about the quality of the understructures that we've seen. What is important is the nail plate is made with a lot of water, is so supple that in trauma it can be intact. So you can have, as you can see in that case, which is the same case, a very severe trauma with a normal nail plate. So when you do nail surgery, you have to remove the nail plate in almost every case in order to get access to the undersurface and to do the repair. If you're just looking to the nail plate, you miss the lesion. So the shape of the nail plate will depend about the bony support, bony and ligamentous support, the quality of the pulp. You can see hook nail deformity in frostbite injury, for example. They do not lose bone, but they lose the fingertip, and then it will bend the nail plate. The nail matrix, the nail bed, the folds that encircle, and some factors that are independent from the surgeon, like BMP4 and some protein and so on. What about the vascularization? Well, the nail unit is very richly vascularized, and healing of the nail is not a problem. You see this small video. I will stop the sound. If you go back, then you see the arteries coming from a volar, and it's coming a proximal arch, which is at the level of the proximal fold. This artery has been described by Flint also. And then it's going into the pulp, which is in the pulp, it's very tortuous. That's why you can use local flaps. And then you will give two arches passing through this ligament, the interphalangeal ligament, one proximal, one distal. And you have a fourth arch coming from the distal pulp to the hyponychium. So it's very richly vascularized, the same for venous and on lymphatic. So it's not a major, it's not a problem. Innervation also is very rich. It's usually follow the vessel. So remember that nail surgery is very, very, very painful. So you need to have a very good local anesthetics if you do surgery, and post-op, you need to give them very important painkillers because it's very painful. So we finished, at least for today, with the anatomy. But basically, if you know the anatomy, you can do the surgery. That's the same for everything, but it's particularly true at the nail and fingertip. Regarding the physiology, there are many factors that increases or decreases the nail bed growth. Most of them are not or cannot be modified by the surgeon. So let's say, for example, we should thank Professor Bean, which is an internist from USA, which for 30 years has measured the length of his left thumb fingernail every Monday for 30 years. So, for example, we know that it grows more faster in warm climate when he moved from Nebraska to Florida to become head of the department, then back to Nebraska and so on. So it's many factors, but we're not, we cannot change that. Some informations, not purely physiology, well, we can produce about 3 grams of fingernails every year, and it peaks, the growing rate peaks about the age of 14, then it goes slowly back. And if you let your nails going long, like these Indian guys, you may access the Guinness Book of Records, but it's obviously totally useless. Nails do not grow after death like hair. Once again, the nail plate is only produced by the nail matrix, no other tissue. There have been a lot of discussion because only primates have nails. So if you want to do, I would say, experiments, it's very difficult, it's very costly, and it's not easy to get into the cage of a gorilla, pull off 2 of his nails and say, I'll come back within a week and I will see what's going on. It will not let you enter once again. So we have a small knowledge about the physiology because it's difficult to get experimental research. The length of your nail depends on the length of the matrix. And because most of the nail plate is produced by the proximal part of the matrix, while most injuries are in the distal part of the matrix or nail bed, so there is less scar with most of injuries. So that's why we can keep nail grow after most of the fingertip injuries. How much matrix can you remove? We don't know exactly, but it has been described that when you do punch biopsies, up to 3 millimeters, it can heal without nail dystrophies. 2 millimeters for sure, sometimes 3 meters. So you cannot lose more than 2 or 3 millimeters. Regarding the nail bed, basically what you can say to your patient is, because we have these ridges that interfere, it basically grows like a patient on an escalator. It goes there and it's going distally. It's not exactly true, but it's close to. So you can say that if your nail bed is okay, once the nail plate is produced, it will be stuck and then go distally to the hyponychium. The nail bed is the most important part for nail attachment. And you know that if you try to pull off your nail, you cannot because it's stuck to the nail bed. There is some potential for nail bed healing in case of loss of substance from the folds and from the hyponychium, at least in some small primates. So maybe in men, some spontaneous healing and regeneration of the nail bed is possible. What do we need to know for the patient? Well, we need to know that basically a nail will grow about 3 millimeters per month. That's 0.1 millimeter per day. So it takes about 2 months to the nail plate to exit from the proximal fold. and about 6 months to reach the distal fingertip. So when you see a patient who has lost his nail, you can tell him that probably he will not have a nail for the next 6 months, or it will take time. And what you can say is also that the first nail plate to regrow is not normal. It's just like pushing the crust, and it's always a little bit festonated. I'm not sure of the English term, but you understand what I mean. And it's a little bit thicker. So you have to wait, cut the distal part, and then basically you can judge the result after 1 year. This is also why most clinical series, they don't have enough follow-up, so we don't know exactly what is happening, because you have to have 1 year, and most patients will not come back just to show their fingernail. After a crushing trauma, this is about apropos of one case, an internist that crushed his fingertip. Well, the nail plate stopped growing for about 3 weeks. So the proximal part thickened, then it speed up, though it's going thinner, and then it's going back. So within about 3 months, the growth rate is not equal, it's not even. So that's why you can see very frequently in patient what we call a Bowes line. Bowes is the name of the French dermatologist would describe that, which is a ridge, a transverse ridge, which is very frequently seen in many cases, but after nail trauma also. So why are the nails useful for? Well, if you go to Zook, he will quote old-fashioned books that said that useful to scratch and defend ourselves from the small species that goes on our bodies. Well, that's true, but it's not usually a major problem. It should not be in most cases. It participates to the thermal exchanges, which explain why we do have a lot of glomus tumors at the fingertip. It's a protection. It's a mechanical protection. If you don't have nail, then the fingertip is much more painful or sensible, at least. It's very important for the aesthetic, and remember that half of the population is a female one, and most of them will paint the nails or use nail substitute, and that's very important. It's amazing how patients are very angry or sad that they've lost something on their nails, because it's very important, because you see your nails every day. But the most important part, which is not to be forgotten, is that it increases sensibility. You have Pacini's corpuscle in the fingertip that are sensible to pressure, but to use them, you need a counter pressure. The counter pressure is the nail plate. If you lose your nail, your discrimination can increase up to 8 millimeters, which is basically no discrimination at all. So that's very important to get a normal sensation on the fingertip to have a normal nail plate. And then it can be used for many things, for guitarists, for like this lady holding his watches, or Picasso used it to scrub. And it's also used as a symbol. And there's a movie which is called Adapt, and it's about child molestation, and the priest is having perfectly normal long nail, just to show that he's clean, and so on and so on. So the nail is very important to most of us, even though it's not a big problem. Let's talk about the injury of the nail, the practical part. Well, they are very frequent. This is a series of about 200 cases, and they do represent 8% of all hand emergency in a hand trauma unit. 8%. So this is something you will see almost every day. The second thing important from that study is that you do have almost another lesion in 2/3 of the cases. A fracture, a pulp injury, a pulp injury plus a fracture, and so on, and so on, and so on. So most often it's not only a nail trauma, it's a fingertip injury with other lesion, and all lesions will interfere with each other. One clinical consequence, do not forget to do X-rays, of course. In any fingertip trauma, you can have a fracture or a foreign body or something special. So X-rays are mandatory for any fingertip injury. Most of them are crushing mechanisms. The door trap finger tips is something you see every day. And most of them, the lesion is in the distal part, basically a nail bed. So they will keep the nail matrix, they will keep some nail plate regrow. So if you can reconstruct the distal part of the fingertip, you can end up with a normal or near normal nail. That's very important. And the third thing is that even it's very frequent, most of them will need some surgical repair, but 2/3 of them. So it's a frequent injury and frequently a surgical injury. Well, what do we need to do nail surgery? Well, we do not need a lot of things. You need a good anesthesia, very important. A tourniquet, digital or whatever you want. Small instruments, of course. An elevator, but if you don't have a free elevator, you just take one tip of a Stevens scissor, for example, just to remove the nail plate, not pulling out every soft tissues. Loops, very important, are small structures. If you want to repair, use non-colored PDS 6O, so very small absorbable suture. And you have to keep a nail or a substitute. I will discuss that a little bit later. That's very important. You do not need antibioprophylaxis for third phalanx injury, even though it's an open fracture. It has been published in many cases, and excuse me, you do not need antibiotics for that. Do not forgive the tourniquet, of course. Regarding infection, it's not antibiotics. And as already mentioned, soap and water and common sense are the best disinfectants. So you will do debridement on the skin. You won't do debridement of the nails unit because it's not a gliding structure. You cannot remove and say, I will pull with my sutures. So it's very richly vascularized. So you just let him in place. Even if it's no more vascularized, you will use it as a graft. But you don't do debridement. You just do lavage on the skin of the fingertip, then you will do the debridement. I know it's highly controversial, but I suggest that you replace the nail when it's possible. And if you cannot, use a substitute, then the bubble trap of the infusion tube, which is available in every OR, is very, very easy. It's transparent and it's already convex and has basically the convexity of a normal nail plate. So very useful. There is many pros and it molds the repair. Sometimes you just put back in position everything, but it's not the suture is not very strong. So molding and protecting the repair is important. It will limit pain during dressing, which is important because it's very painful, and then remember. And it also helps to increase the sensibility at the beginning of the repair, so they can use the patient can use their finger because they have a counter pressure. But it's a foreign body. This is definitely a foreign body, and if you want to avoid infection, at least do a hole for drainage, please. Regarding the different trauma that we will see, well, the simplest one is lumbago hematoma. And as you know already, it's very painful. It's painful because it's It cannot evacuate due to the seal of the cuticle and the lateral fold. And it develops in the matrix zone because the nail bed is very adherent. So it's very proximal, very close to the proximal nail fold. If it's less than 25% of the surface of the nail plate, visible nail plate, do nothing, it will incorporate and will follow the nail regrow and disappear. Zook put the cut at 25%. They say if it's more than 25%, you can go and do for surgical repair. I don't think so, but well, if it's a little bit important, you can do either drainage or a repair. We'll discuss that next slide. If you do a drainage, it could be close to the nail fold. Try to do 2 holes. It could be a hot paper clip or the tip of a needle to evacuate. And I do recommend that you put some Steri-Strip to maintain the nail plate in position, because sometimes it bleeds a lot and it can we say, recur. Regarding the nail plate removal and repair, I'm not in favor of that, because there are some studies that have shown that when you open, basically 1 out of 2 cases, you cannot do anything. It bleeds, yes, but it's so small that you cannot do any repair for that. So this is the first reason. If you remove the nail plate to a patient for nail bed hematoma, 1 out of 2 cases, you will do nothing. Put the nail plate in position with a hole, and you can do the hole without going to the OR. And prospective studies have shown there's no difference into the quality of the nail regrow if you do either a nail plate removal plus or minus repair, or simply a drainage with a paper clip. No difference, even though there is a fracture. If you do that, you open the fracture that was closed, but it does not change anything. So I prefer the simple drainage. Foreign bodies, well, you can remove the nail plate, remove the foreign bodies. This is easy. I was very happy when I saw that those papers, they say, well, you can do that without anesthesia, which is important, and you use just a blade and just remove some chips of the nail until you reach the foreign body. Well, you can do that, of course. It's possible. It's described in every emergency textbooks. But I must admit that it ruins the nail plate. You have a big U, that's terrible. Basically, it's better to go to the OR and remove the nail plate. That's very important. But don't try this one, except if you cannot go to some repair, some OR. If we're dealing with a third trauma, which is nail bed injuries, I mean the injury in the distal part of the nail unit. Well, basically, it's quite easy. It's quite straightforward. You remove the nail plate. Remember, it's so supple that sometimes you cannot see the lesion. You wash the injury. You don't do any debridement. If there is a fracture, you will reduce it. Sometimes fix it. Take care of K wires at that level, but well, you can do that. If there is fingertip injury, fix the skin first with 4 sutures, for example. That will stabilize the support, and then you can do a running 6/0 suture with a PDS, and that's all you need. And put back in place a nail or a nail substitute with a drainage in that, a hole in that. And with that simple technique, you can expect more than 90% of good to excellent result for most simple lesions. So it's very easy. We do not need to talk a lot. It's just a suture. Well, sometimes the cases are a little bit more severe and more crushing. Well, it does not change anything. Principles are identical: no debridement, lavage, And if you have non-vascular spot, you will let them in position and they will act like grafts, like nail bed grafts that will heal, mold the repair. It's most important in that case, and you'll get good success. This is an example. You see this trauma. When you remove the nail plate, you see there's a lot of crushing tissue, but you can repair it, the skin plus the nail bed. And put a substitute, and you get a simple follow-up. If there is an associated fracture, most of them are non-displaced or in the tuft, and they do not need anything. If you need to stabilize a fracture, you can use needles, you can use K-wires, but try to not to use it too frequently because you can have infection around the K-wires. I'll go a little bit later with Fouché synthesis. This is the Fouché synthesis is the obanage with the nail. Fouché described that for transverse injuries with a fracture, and he used a nail, he used a 2-0 suture, put the needle, leave the needle in position, and use the sutures to make the obanage around that. So it's very tricky, it's very intelligent. The problem is when you try to remove the needle at 2 to 3 weeks. It's so painful that sometimes you have to go to the OR. So we change a little bit the technique of Fouché, and we use the sutures. So we use the needle, but we leave the suture in place. We don't use the needle anymore, and we do simple sutures. That is very useful for some cases if you just need to use a plate that will stabilize every structure under this. If we miss some nail bed, well, turn the nail plate if you have it. Very frequently, the nail bed is attached to it. Then either you put the nail back in position and you have a good pre-tension graft that will be exactly at the good level and that will heal very simply, or you can detach it and put it back in place as a graft, like in those two cases. You see on the bottom side, left-hand side, the soft tissue of the nail unit, which is lost and which is placed in position back, which is very simple. It's just like a skin graft. Nothing is very difficult. Sometimes you need to take a nail bed graft from another tissue. You can use a dermal graft. It has been used. Well, if I a complete nail bed graft, so I would prefer nail bed graft. If I complete nail bed loss, I would prefer nail bed graft to a dermal graft, but you can use it. It has been described with very acceptable results. The problem is you have to take a split thickness, otherwise you will destroy the nail bed of a normal finger or toe. And in the literature, you will see that you can take the graft from the same finger. Well, if I go to the OR for a crushing injury of the finger, there's no more space that are available for grafting, or very rarely. So if I need a nail bed graft, then I will go to the great toe, lift the plate over, and try to take a split thickness, which is not very easy because you need to take 300 micro, but the hallux is very convex. So it's very difficult to be even, to take the same thickness of the graft on a convex size. So that's why when you take a nail bed graft on the great toe, you can end up with some dystrophy, not a major dystrophy, but by 25% of cases, they will complain of a little dystrophy. So this is a nail bed graft in position and 3 months follow-up. Well, sometimes you have a finger bank. Well, perfect. So you take the nail graft, the nail bed graft, you can take the full thickness nail bed graft back in position. If you take a full thickness, it should be oriented proximal to distal. If you take a split thickness, you do not take care of the orientation. So in some fingers, you can use the matrix. More important trauma, the distal fingertip amputation. Well, most distal amputation go to the nail bed. The matrix is preserved. So if you can replace in position, you can have a normal nail. When replantation is possible, well, it's obviously the best treatment, but it's very, very difficult to do microsurgery on the distal part of the fingertip. It's very rare that you have a very clean cut that allow you to do the micro. And even though if you do a replant, a finger replant, you will observe some nail dystrophy due to the ischemia. Well, if the replantation is not possible, we have all tried the reposition. You have the small fragment, the fingertip back in place, do some skin sutures. It's very difficult to give you a clear knowledge of what you can expect for that. Some have claimed very good success if done very early. Others have claimed success if it's done in children. Well, most often it will heal as a necrotic tissue, but it will heal as a biologic healing dressing, and it's worth trying if you have the small fragment. Hirase, which is a Japanese guy, has proposed to put the finger into the cold, into the fridge basically, for 1 or 2 days, and he claimed 90% good success. I have tried to use this technique. Well, you use the aluminum sheet of the sutures, put over the fingertip of the patient, and you try to leave it into the ice for 2 days. Well, basically, if you put the ice around the finger, you will have water everywhere in the bed of the patient. If you try to leave it into the ice when you slept, you move. So I have not a good experience with that, but the idea is very, very intelligent, very clever. This is an example. It was a lawyer, and she came with a fingertip. She just cut with a cutter a few minutes ago. So we were able to just put back in position, and we had a healing of the skin and a healing of the nail bed at the same time. So it's worth to be tried if you have the fragment. If you have the fragment, cannot do the replantation. If you have a fragment that it's too big, you can try. You can try the reposition technique, which was described a long time ago by Montero. The idea is to use the bone and the nail apparatus as a graft that you put back in position K-wise, and you replace of the pulp by a flap, whatever the flap you want. This is an example in a young guy. The problem with that is that there's always some bone resorption of the distal part of the fingertip, and you end up with a hook nail deformity, but you end up with a nail, sorry. So in some cases, it's worth to be tried. And sometimes you just need some distal part of the nail bed and of the fingertip. Well, Guy Fouché published his technique. He used a flap. This is an atazol flap, and he used to remove the skin of the distal part to use the de-epidermized part of the flap to reconstruct the nail bed. So the flap will reconstruct the fingertip and the distal part, the nail bed, just a dermal graft, basically. And in the series of cases we looked after from Fouché, this is a publication, we got a regrowth of at least 75% of a normal nail. So it's very worth trying. Doing an atazol flap is not something very important. And you just not try to put the skin to the distal part of the nail bed, but you try to use a small part to reconstruct and lengthen the nail bed. That's very, very clever, but it was, even now, if I'm the first author, so Guy Fouché was the idea. And not to forget that in some cases, this is a sugarcane injury. Well, you just put everything in position and you get something with some nail, and you can have some acceptable results. Do we need to repair the nail bed? I mentioned that in small primates, there are spontaneous healing and regeneration of the nail bed from the hyponychium and the folds. And a guy from USA, his name was Oguro. This is a picture of Oguro. He used to present his topic with him in that dressing. This is a slide he gave to me. He designed a nail plate substitute. He say, don't do anything, just put my nail plate back in place and you can obtain a normal nail regrowth. So there's probably some regeneration that is possible. I would not suggest to use only the nail plate substitute, but in some cases, and even recently, I had a nail bed loss and say, well, this is not a good patient for a nail bed graft, just put a nail plate and we'll see, probably we can get some healing and some regeneration. What about children? Well, children have the same nail apparatus that we have, and the principles are the same. The problem is you need general anesthesia if they are small children, but if you don't do that, then you will have more failures than if you do correct surgical repair. So even though it's difficult to get access to the OR and the parents are very anxious, surgical repair follows same principles. And especially be aware of this very special lesion called Seymour's fracture, which is basically a gross plate injury. You need to go to the OR because very frequently the nail matrix is entrapped into the two parts of the bone, and if you cannot correct that, you will end up with a very severe dystrophy or an infection or whatever it is. It has, even in one case, I'm aware of one case where they describe a flexotenosynovitis from a Seymour lesion. So the bacteria came from dorsal, get to the sheath, and went down. So the Seymour lesion in children is an indication for surgery, no question about that. And very frequently you have to put a KY to stabilize this type of lesion. More proximal, the matrix injuries. I'm already a little bit late, but that's okay. We're close to the end. Well, the principle is the same, but the sequelae are more severe because you are touching the protrusion of the nail plate. The nail matrix is proximal to the nail fold. If you want to get access, use these two incisions who were described by Canaveral from Chicago a long time ago. And then you can switch over the proximal fold and get access to the matrix. And if you need, you can extend this lateral incision to the DIP joint. And if there is scarring, it will be hidden by the lateral fold. That's why you don't do middle incision, because if you have a scar, it will be visible as a ridge. If you are lateral, then you can have a good access with little or no sequelae. This is an example of a more severe lesion of the matrix. We repair the matrix, we repair the nail fold, we fix the nail in position, and we obtain some. There were three fingers, just the same, and you see there are some sequelae, but the patient has a nail that is regrowing on this fingertip. Regarding the paronychium, basically you need to reconstruct the paronychium. So use flap, whatever flaps you want to reconstruct the paronychium. This is on the left upper side, a flap done in emergency. On the right, this was a small flap, and some time to avoid the flap to go back due to scarring. I put the dressing into the trench, so it avoids some I don't know the term in English, but your flap going back due to scarring. So what is important is if you don't want to go to nail dystrophies, you have to prevent them. So repair all the lesions we mentioned. That's very simple. Repair the support, the pulp, the bone, repair all the things and back in position. If you go to books, there are 50 techniques for nail dystrophies, about 3 cases, 2 lost to follow-up for the first 1 year. So basically, we do not know what to do. And when you discuss with those people who have experience with that, they all confess that they have very poor results. So prevention is the key, okay? For the pterygium, which is the scarring tissue, the scar between the proximal fold and the underlying matrix, I suggest once again to use the nail plate or nail substitute under the fold to prevent abnormal scarring, because when you want to treat those patients, it's very difficult. So complication of nail injuries can be prevented by the knowledge of the anatomy. This is the basis of surgery. It's nothing so special. The second thing important is you have to consider that this small organ is worse to be handled. This is not something for the first-year resident to say, okay, I don't care. This is difficult. It has to be done. You need loops, but as I mentioned here, you do not need to be a skillful surgeon. It's just simple sutures. But if you do that, you will prevent most of the complication, and this is the key to success. Thank you very much. Thank you for the BSSH for your invitation. Thank you for listening to me. Thank you for attention.
Christian, thank you so much for a masterclass in nail injuries. That was absolutely great to listen to. Really clear, really well illustrated. So we have got a few questions, if that's okay.
That's okay, if I may answer.
Yeah. So the first questions are about fixing the nail plate. So I noticed that on your photographs, you show a figure of 8 suture is your preferred way of holding the nail plate in position after you've replaced it. And you do yours from lateral nail fold to lateral nail fold. Yeah. And when you look in the books, there are so many different techniques, aren't there? There's little loops to hold it to the hypernychium. There's loops that go underneath the germinal matrix. How long have you been using your figure of 8 suture for? And go on, you answer that bit first.
Well, for a long time, it's Alain Gilbert who told me that exactly. Well, you can do what you want, basically. What I do not recommend is using sutures going into the eponychium or the proximal fold, because if you do an injury, then you will have a dystrophy, and you do not need that. I like the X sutures from one fold to the other one, because you do not need to go with your suture through your repair.
Yeah,
you can do that, but the nail plate is a little bit strong, so you had a crushing injury, just put 6/0 suture, then you want to go with the 4 through the nail plate, then you are going to have trouble. So this is very simple, because you just need to fix the skin with a hex type. Sometimes I do a little small trench in the distal part to hold one of my suture. The major problem with that is the patient are painful, because you compress the finger to the top.
right.
I use absorbable suture, so within a few days it's okay. But well, the major drawback is that they are painful because they feel compressed in the
Yeah.
finger.
Yeah. So that's the nail plate figure of 8 suture. So that did you just say that that's the absorbable suture, or is that an additional suture?
Well, usually when you have fingertip injury, you will use one of your stitch also to fix the skin at the same time. Yeah. So it simplifies your repair.
Mm.
Well, but any technique is okay, but going through your repair,
I
would prefer not. I would prefer.
Yeah. And how long do you leave your figure of 8 suture to hold the nail plate for?
Well, at the moment, I'm using absorbable, but you have seen some non-absorbable suture.
Yeah.
I will remove them within 2 to 3 weeks.
Yeah. Okay.
And then the plate will fall out within a few days.
Yeah. Yeah. And there's a question about, is it essential to tie the nail plate down to the sterile matrix and germinal matrix? Philip, who's asked the question, says that he doesn't think that that's essential, and I don't think it's.
There is no clear answer about that. There is one important paper, which was a good one, in children, and there are more complications putting back the plate in position than doing nothing. But I must admit that it's not very scientific. But for 30 years, I'm doing nail surgery, 35 years almost. I had very, very, very little complication with that.
Yeah.
And I have not seen any complication that I thought was due to the replacing of the nail plate. And because I'm very anxious about derision, I will put back the nail plate into the fold. If you just put it here, it's okay, but you do not protect the folds from adhesion to the matrix. So I would suggest, if you consider nail plate replacement, put it back like it was before.
Yeah. Yes, I think that's it's preventative, isn't it? It might not be every patient with a germinal matrix injury that's going to get a pterygium, but if they do get that, then the options are very limited, aren't they?
Yeah, it is.
Yeah. Have you, when there isn't a nail plate, what would you use?
Well, I told you I use the infusion tube of the anesthesiologist. It's always into the OR, so you just cut it. You have all you want, and the curvature basically is okay. If you need to just decurvate, I'm not sure it's a good term, but just mold a little bit to it's the good length, the good thickness, sorry, and you can cut what you want. It's transparent, so you can see the dressing after that. If you use X-rays, like it has been published, it's too thick and it cut the patient. It's a little bit too sharp. Silicone sheet are much more expensive, and they are too soft. So the infusion tube is okay, and it has already been published by a guy from Italy, Pierluigi Tos. I was not aware of this publication when I tried this.
Yeah. And we got a question about the suture material used for the nail bed. So you're using 6O PDS, and Thomas asks, we're using Vicryl Rapide. Does that sound okay?
Yeah, I don't have 6O. The problem is the Vicryl Rapide 5O. It's the needle is a little bit too big.
Yeah.
For those lesions. I would consider 6O, but if you have Vicryl Rapide 6O, probably it does not change anything to the repair. Probably not.
Yeah, thank you. And I also particularly like your emphasis on not debriding the nail bed itself in injuries, because so many of the training that we've had, or the books say meticulous debridement and repair of the matrix. But I agree with you, you just can't debride it, because then you've created a hole, haven't you?
If you debride the nail matrix, then you have no nail.
Yes. So we've got you cannot
debride anything, because there is no dermis or hypodermis between the nail bed and the bone, so it cannot glide.
Yeah,
and that's why for sutures, when you use 6O, for example, that's why you need small suture. you cannot switch. You just follow the curvature of the needle, and you take big pieces regarding the nail, because you just can do this, but you cannot try, like for the skin, to do this type of movement, because it cannot glide. It cannot glide. Sorry.
Yeah. I've got a question about the subungual hematoma when you trephine it. If there's a distal phalanx fracture, there are some publications that recommend using antibiotic ointment to dress the wounds, because theoretically you've converted a closed fracture to an open fracture. Have you ever found that to be needed?
I have two answers. First, I'm an Ayatollah against antibiotics, so I'm not maybe the good one, but there is evidence in the literature that you do not need antibiotic prophylaxis for fingertip injury and fractures, open, close, whatever you want. And there is many papers about that. And at the moment, the French Society is going to do a review, and there is two already published review that show that there's no indication. For nail bed hematoma, the same apply. Basically, it's not a problem. And regarding antibiotic ointments, it is not recommended in any situation on the body. So there's no reason that it could be recommended only for the nail. So I have no experience with that, but I would not consider it. I don't do anything else but drainage of the hematoma, some lavage sometimes, and that's okay.
Great, thank you. I have a question from Anastasi, who's asked, when you're ablating a nail, so ablating the germinal matrix, can you excise the germinal matrix and leave the sterile matrix as soft tissue cover?
I'm not sure I understand the question. If you excise the germinal matrix, you won't have a nail anymore.
Yeah.
So you can leave the germinal matrix if you need to cover the bone, but it will be a non-nailed fingertip.
Yeah. So it'd be basically like just skin to cover something. Yeah.
Sometimes in some tumors, I've been able to remove only the matrix because I had to and leave some of the germinal of the nail bed. So you need a smaller dressing or a smaller graft or some other thing, but that's all.
Yeah.
But you remove the matrix, no nail. No question.
Yeah, thank you. And then
Jill, I'm a bit conscious of the time. We'll have one more questions, then and then we'll stop it. Yeah. Otherwise, we're going to have Christian here all night.
Yeah.
It's a pleasure.
Right. So I've got a question for you then. Because of the concern with the sterile matrix and creating a hook nail, if you're doing an advancement flap, a reconstruction, how do you anchor the leading edge, the distal edge of your pulp flap to the end of the fingertip?
Well, one first answer is if you try to avoid this hook nail deformity, you have to oversize your flap. So that's why I'm not using atazoid flap very frequently. If I need a flap for the distal part, I will use the TLA flap described by Elliott, which is basically, it looks like an atazoid flap, but it goes from the PIP joint. And then you will have enough tissue to cover. Because the atazoid flap will cover 5 millimeters, not more. And then you will have tension and tendency to hook. So if you need a flap, a big one. Then the end of the flap, you can desepidemize, so to lengthen the nail bed, if you have the bone. If you don't have bone, it's another issue, but it will give you some support. But the support should be oversized, otherwise you will end up with a scarring with some bending of the nail.
Yeah, that's great. Thank you very much. Okay, Carlos, I'll stop.
Brilliant. Thank you very much. Actually, that is a masterclass, Christian. Thank you very much. And some of you will have realized how much there is to know about the nail. And I can say that Christian years ago published a whole book on the nail. It's a whole booklet. It's worth looking at the library or trying to get it, because these little problems can give you a headache, actually.
Well, this book is supposed to be republished that year, and it will be in English, so it will be available to most people, because the first one was in French, so not easy to read.
We have a very intelligent audience, I'm sure they can read in French, or at least they can look at the pictures, even they're in French.
Of course.
Which is what most of us do. No, that's been fantastic, Christian. Now, just to go back to what I was saying before, we're going to have a break for 2 weeks, and then we're going to come back with Jeff Greenberg talking about distal radial joint instability. Thank you very much to the audience for joining us. Thank you very much for Jill for sharing professionally as always, and particularly for Christian for spending his afternoon with us in the hot weather of Guadalupe. Fantastic place in the Caribbean. I'm going to put you the picture for the feedback. Please fill in the questionnaire before you go, and I'm going to put you the links in the chat as well, just as we speak. Feel free to leave your comments in the chat as you come back, and have a good evening for some of you. Good afternoon to Christian, and good night to everybody else. Have a good night, guys.
Thank you very much. Thank you for your invitations. It was a pleasure. It was a pleasure.
That's been fantastic. Thank you very much, Christian.
Thank you.
Thank you. Thank you so much. Excellent.
So just give you this.
Oh yeah.
Okay, Christian, if you want, have a look at the chat and you'll see all the comments from the people.
Okay, I will, for sure.
That was great. Thank you very much.
Thank you. Thank you.
Thank you, Christian. Bye.
Thank you.
And apologies to those of you who didn't answer all the questions. There were lots of questions. Sorry we didn't get through all of them. But thanks. Good night, everybody.
Good night. Thank you very much.